indeed. So that was a very kind introduction, and I have to say it makes me sound much more impressive than I really am. But thank you so much to so many people for registering and logging in tonight. So it's so nice that so many people are interested in menopause and women's health. So well done. I just want to say before we begin, I'm only able to do this event tonight and sort of share sort of my knowledge with you because of a great team that are working behind me here. So thank you to BMI for, promoting women's health, helping us get the message out there about menopause, as Louise said, trying to sort of remove the taboo. So let's see how we get on. I just have to also thank Davina for doing a nice little kind of warm-up gig for me last night. So for those of you who don't know, Davina McCall did a really good program on Channel 4 last night. All about menopause, and I would encourage anyone to sort of take a look at that. And all credit to these women who are in the sort of public eye, putting themselves out there and sort of helping other women. So onto business. Let's see how we get on. So what am I going to cover? And I just want to say thanks so much for sending in some questions as well. I have to admit I might not be able to answer all of them tonight because there's quite a few of you registered, but I will do my best. And hopefully when I'm sort of talking through stuff and what I'm covering, I'll cover most of these questions. But the way I'm going to do it is at the end of the session, we'll have a sort of a question and answer session. But unfortunately, I can't invite you on live to ask your questions because there's quite so many people. But let's see how we go, and I'll get through as many as we can. So what I'm going to cover. So first of all, there'll be some of you sitting there who haven't been through the menopause. So, I'm going to sort of help you know about what to expect, what typically happens, what type of symptoms you can get. But then also, I want to mention a bit about health implications of the menopause. Lots of people don't realise what they are, so I'm hoping to share that with you. Then I'm going to move on to what you can do to sort of help yourself. I get a lot of questions, particularly about things like sleep, weight gain. I'm going to talk a bit about that. And what you can get over the counter. Then I'll move on to sort of what a health professional can do for you, and not just me. I'm talking about your GP. I know there'll be some of you who are logging in from other areas, not the Bath area tonight. So hopefully this will help you feel informed as well, and feel that you can go to whichever health professional is near you and be a bit more informed about what your options are. And of course, HRT, that's what everyone wants to know about, the hot potato. Giving you a bit more detail about the sort of risks and benefits of HRT, how to apply that, and how to also dispel some of the misinformation that's out there. Just in case you're starting to fall asleep and you sort of start to get bored of my voice, I've obviously got to talk a bit about sex and libido, so we'll bring that in later on. I know that's why you're all logged in, really. So we'll chat about that, and then we'll see how we go. There's a lot of myths out there about menopause, and particularly about HRT and treatment. So I'm going to sort of hopefully debunk some of those for you, and then also scientists give some helpful information about what you can do in your workplace, information for employers and employees, and then we'll get on to some questions. So it's a speedy need to know through menopause. Hopefully this will be useful for you. Okay, so why is menopause so relevant? Well, let's face it, half the population are female. We're all going to go through this at some point. But if we look at why it's even more relevant now, is if we look at demographics, in 1850, the average age of the menopause was 45. The average life expectancy was 45. So it didn't really matter so much then. Now, the average age of the menopause is 51 and life expectancy is 81. So what that means is we're potentially going to spend over a third of our lives in a menopausal state. I don't know about you, but I want to feel good for that third of my life. So when does the menopause typically happen? So, well, as I've said, the average age is 51, but everyone's a bit different. So anything between 45 to 55 is within normal limits. If you're under 45, that's what we call a sort of premature menopause or an early menopause. And if you're under 40, is what we define as something called premature ovarian insufficiency, and that is one of my areas of specialist interest. So what is menopause exactly? Well, the menopause, the word itself, all that means is it's a year with no period. So it's a arbitrary day that happens where you've had a year where you haven't had any periods. And often it can be hard for women to know exactly when that is, because there'll be some women who've maybe had a hysterectomy, they might have got a Mirena coil, they might be on the mini pill and not having periods. So sometimes it's harder for some women to know when that happens. But typically what happens is as the ovaries start not working so efficiently, as they start sort of failing towards the end of our reproductive life, our estrogen levels fall, and also our progesterone and testosterone levels drop. So, so what do you expect when this happens? What sort of typically happens? Well, the key point here is everyone's different, everyone's individual. So some people might notice first of all that their cycles get a bit shorter. In fact, they stop bleeding every 3 weeks. Some people may notice their cycles getting a bit longer. And then you might start missing the odd period here and there and getting weird, unpredictable bleeds. So everything can be, everyone has a different experience. Some people notice that they can start getting heavier bleeding. Other people notice that their bleeding can get a bit lighter. So as I say, each person's an individual. There's not one size fits all. A lot of women do comment that their premenstrual syndrome gets worse. Hopefully, there's a few men in here sitting with you whilst you're watching this tonight, ladies, but, buckle up, fellas. But the good thing is I might tell you all these things, but I'm also going to tell you what you can do to help. Okay, so what about menopausal symptoms? What are the typical ones? Well, a woman's sort of relationship with menopause is complicated. Now, in this country, we're really lucky. We've got the British Menopause Society. And they're a sort of group of very clever people that put together all the data so doctors like me can help sort of deliver out to people and help advise and GPs as well. But when we look at menopause, and some of you will have heard Davina talking about this last night, so 45% say it can impact on their work life, that you've got people where it impacts on their social life, it affects your libido, your relationships, so it can be really significant. So in terms of symptoms, well, 25% of people have none, so aren't they the lucky ones? So I wouldn't shout about it too loud if that was you. But 75% of women will get sort of hot flushes and sweats. Not everyone gets hot flushes and sweats, but quite a high percentage of women do. And it's really important at this point to say that menopausal symptoms, it's a spectrum. So some women will cruise through it, not really notice it happening. Other women will be on their knees. It's every week in my clinic, I will see someone who's literally suicidal because they're struggling so much. I have to say at this point, it's a really important message that's nothing to do with whether you're a coper or not. I've seen lots of very capable women, very successful women, who have coped with many things in their life, and actually suddenly that drop in hormone can floor them. So it's luck of the draw how your body reacts to that change in hormone. Now, the other common misconception with menopause is sort of, this can't be my menopause because I'm still getting my periods, or, well, actually, some women get the worst of their symptoms in what we call the perimenopause, so that run up to your period stopping. Some women will get them around the time of the period stopping, and some women will get them, later, a few years. I think I've been there, I've done it, I've not had a period for a few years, and then boom, that low estrogen catches up with them and they get symptoms. So it's a lot of people will start getting their sort of perimenopause symptoms in their early 40s actually, and that's often when you're not really thinking about menopause, but suddenly you're feeling very tired and getting all these weird symptoms that you don't know what they are. So typical symptoms. So as we say, look, everyone's heard of hot flushes and night sweats. So the other common ones that I get are not being able to sleep, that sort of typical brain fog, the memory issues, hair can change, skin can change, and people get bladder symptoms, aches and pains in the joints, like standing up feeling a bit like an old lady, vaginal dryness, loss of libido. Yeah, but I'm full of this, all this doom and gloom. Everyone's sitting there feeling utterly miserable by now. But don't worry, we will talk about what to do about these things.
Kate, I'm so sorry to interrupt. We've had some, I think we've got some audio issues. Okay. So what I'm going to do is I'm just going to pop a laptop next with the microphone on. Yes. Hope that improves it. If everyone could let us know if that doesn't improve it, that would be really helpful. Thank you.
Sorry guys, technical issues. Okay.
that their symptoms, after a few years will settle. Other women, sadly, will be still having symptoms in their later years, in their 80s, 90s. I think my oldest patient at the moment is 88 and still getting symptoms. So everyone's different. So what about those risks to health with the menopause? So central obesity, so often that your weight pattern changes and we're more prone to that sort of central obesity thing. I'm going to come on to weight in a little bit and tell you my tips of, how to manage that. We run into risk with osteoporosis, more cardiovascular disease, type 2 diabetes, cognitive decline, dementia goes up, and of course, as I've said, the sort of mental health issues. So what about the positive things we can do? What about the lifestyle advice we can do? So alcohol, yes, I'm afraid Prosecco is not the menopausal woman's friend. A lot of women will notice that as they go through the menopause, they become a bit less tolerant of alcohol, unfortunately. Believe me, a lot of this is do as I say, not as I do. But we do find that things like white wine, which contains sulfites, often you can't tolerate as well. So sometimes drinking expensive wine can help, or organic wines can be better. But a lot of menopausal women might prefer to sort of drink like a gin tonic or something because there's less sulfites in it. Because life's still for living. It's really important that we kind of are still, able to get out there and enjoy ourselves. But unfortunately, it can trigger those hot flushes and sweats. So, it is important to sort of not drink too much. I think it's been quite hard, hasn't it, in the pandemic, because a lot of people, have felt more anxious. A lot of people are drinking a little bit more than usual, but it's quite important just to, stick within the sort of recommended limits, really, not more than 15 units of alcohol a week. So we all know we shouldn't be smoking by now. I think that's been hammered into us by this age. Spicy food can trigger flushes. It's important to drink enough water. Caffeine, I try and say, perhaps no caffeine after 3, so that it's not sort of impacting on your sleep. And different things, like little tips, some people might have 2 separate duvets when they're sleeping in bed at night because their husband's sick of them pulling the duvet off all night. So you can have one for him and one for you, or her and her, whoever is in bed with you. And often sleeping with the window open can help. Sleeping on a towel so you're not having to change the sheets in the middle of the night. So what about in the workplace? It is important to sort of say to your employer, you know, I'm struggling, I might need to work with the window open. It's important to communicate so that it sort of helps you during this sort of difficult stage. And often layering clothes can be useful. So if you're in the middle of presenting a meeting like me, you should have had an extra layer that should be able to strip it off, and that can be useful. So one of the common things that women ask me about when they come to clinic is weight gain. And yes, that is a genuine real problem, because unfortunately, as we get older and go through the menopause, as I say, the weight tends to shift from your hips to more sort of on your tummy, at that sort of central pattern. And your kind of muscle mass diminishes and your fat increases, depressing, and your metabolic rate slows down. So a lot of people will say, look, I'm doing all the things I normally do. I'm still exercising as much. I'm not eating more. I'm not drinking more, but I'm just gaining weight. And that's, you know, it is a very real thing, unfortunately. And I have to say, it's a stage of life where you're probably not going to want to hear this, but we do just have to work a bit harder to maintain it because, you know, of these changes that naturally happen. Obviously, I'm going to come on and talk about HRT and how that can help. But, you know, when I'm saying we need to try a bit harder, it is the old adage, you know, people will say, what can I do for this weight gain? And unfortunately, it is the move more, eat less, drink less alcohol. But, you know, I think if we sort of talk about exercise, a lot of us do lots of walks, and particularly, you know, during the pandemic, we've all been doing more walking, which is brilliant. And, you know, something's better than nothing. But what you should be aiming for when you're menopausal, if you want it to actually help your symptoms, is at least 3 episodes of out of breath exercise of 30 minutes per week. So I'm afraid those steady dog walks aren't going to really cut it. You really need to get yourself out of breath. So if you're going to go for a walk up a hill, try always walk up the stairs, don't take a lift, and you know, you don't have to start going to the gym if you're not into that, but it's you know, you do have to try a little bit harder. This is our stage in life where we've got to take a bit of positive ownership of this and really, you know, look after ourselves a little bit more. So what about supplements? People often think, well, what can I take? What can I get over the counter? I'm not ready to take hormones yet. What can I try? I always think you can tell a menopausal woman because you go to her kitchen cupboard and you can see it's becoming fuller and fuller of supplements until they eventually go, oh my goodness, maybe I need something else. But I think everyone should be taking vitamin D, especially when we live in the UK and we don't get much sunshine. I would strongly encourage you to sort of take a vitamin D supplement, and if you go on the NHS Choices website, it gives you guidance of what sort of doses you should be taking. What about other, and you know, especially with COVID as well, there's evidence it can help, you know, boost our immunity. So I would say, you know, it's a good thing to be taking. Other supplements, a lot of them don't have much evidence behind them, but the ones that do have a tiny bit, red clover, you would have seen on Davina last night, Promensul, that is a supplement that has a tiny bit of evidence behind it that it can help, but you can try it, but sometimes it doesn't always sort of cut it. Sage, there's a lot of the cancer patients I see who often struggle to know what supplements they can take, and there's not that many that they can take. I often say sage is a good one, and it's not like the sage you put in your food. It's actually sort of white sage, so it's like a supplement. So you get that in, I'm not allowed to advertise any shops, I don't think, online, am I? But in your typical chemists that you have on the high street. So magnesium, I mean, this is more an anecdotal one for me from working within this field. I think a lot of women who are experiencing anxiety in the menopause do find that magnesium can be helpful. I haven't seen much evidence, like data on that, but there are so many women that say it helps that I think there's something in it, and it's certainly not going to do you any harm. So that would be my sort of short guide to the supplements. Your black cohosh, things like that, a lot of the European women are taking that. Whoops. But I would say that, you know, that can interact with some of the medications, so just be a bit cautious with that one, along with St John's wort as well, which is great for some people for mood and things, but be a bit careful because it can interact with your regular medications. If you are going to get something over the counter, always look for this little sign, because it means they just have a little bit more regulation behind them. So, and as I've said, you know, this is a stage in life where sometimes we need to apply a bit more self-care than we did before. So, you know, don't forget to sort of, you know, take a bit of time. You know, it might be that talking therapies might be useful middle age, if that's when you're going through the menopause. Obviously, some women go through it a lot younger, but it can be a very challenging stage in life. There's multiple stresses on you. It's not only, you know, often you can have elderly parents, you can have teenage children, you might be at the top of your career with lots of stress, you might be struggling because you wanted to have children, you couldn't, you know, lots of different scenarios. So often, you know, we need to just look after ourselves a little bit more, and things like, there's a lot to be said for like relaxation, yoga, meditation. I worked for many years in reproductive medicine, and I did have a sort of slight enlightened moment. I remember one day I was doing an IVF procedure, collecting someone's eggs for them, and normally we give them a lot of sedation and pain relief. And I'll never forget, I had a yoga instructor come through, maybe she's logging in today, but and she said, I don't need any of that, I'll be able to get myself in a relaxed state. And I was like, no, really, you know, I'd recommend you have something. Well, I'll never forget seeing the sort of meditative state she got herself in, and that she didn't need any pain relief, anything. And it was really impressive, and it really taught me the power of some of these alternative therapies. And if you really work at them, how good they can be just for your general well-being. So cognitive behavioural therapy, this is something I do feel very strongly about, and a lot of people, sometimes when you recommend psychological therapies in the menopause, people can think they're being fobbed off, and that is not the case at all. Actually, there's really good evidence that it can reduce hot flushes and sweats by up to about 50%. So, and the other thing it can do is, even if it doesn't totally remove the symptoms, what it does is it reduces the impact that the symptoms are having on your life. And this is relevant for me because I work in the oncology menopause clinic, and some women who can't have hormones, we need to have other things we can suggest. And I have seen a lot of women have success with this. I've put here, and just to reassure you, at the end of this talk, I'll be linking you to lots of sort of good websites, and feel free to screenshot anything. But the Women's Health Concern has got a really good leaflet on how to teach yourself cognitive behavioural therapy. It's all about breaking that vicious cycle. It's that sort of, oh no, I'm going to have a hot flush, I'm at a meeting at work, oh no, everyone's going to look at me, and I'm going to be sweating, and it's all about how to break that cycle. And actually, if you change that sort of framework, then it can reduce the hot flush being so severe as well. It can actually change the physical symptom. So certainly don't underestimate the power of cognitive behavioural therapy. So sleep. Many women I see will say, I'm struggling with sleep, and the reason I wanted to mention this in particular is because I do think it's sometimes quite helpful to know. You know, if we look at a normal sleep cycle, actually we're designed to wake up a couple of times a night, and sometimes women like hearing that because it's a little bit more reassuring, because a lot of us will wake in the night and then think, oh no, I'm not going to be able to cope the next day, what am I going to do? But actually we're designed to do that, and the really good bit of sleep happens, that sort of cellular restoration, or that bit that you need for your health, happens in the first 2 to 3 hours of sleep. So if you are waking in the early hours, you can think, well, actually the good bit's already been done, it's not the end of the world. And sometimes I think that can be quite calming when you're sort of not sleeping in the night, if you know that's okay. I think, you know, everyone's trying to get the magic 8 hours sleep. We don't all have to get that. 6 to 7 hours is okay. If you are really shattered in the day, as lots of people are, particularly when you're going through the menopause, try and have a sleep after 3, otherwise it will impact on your sleep depth for sort of sleeping later. So, and you know, if you do wake up, be kind to yourself, you know, don't put all the lights on and the telly on, but just let yourself get up, let yourself cool off, open the window, have a glass of water, but then sort of get back into bed and reassure yourself that you will still cope the next day. It's okay to feel tired in the morning. And let's not forget that Margaret Thatcher ran the country on 5 hours a night. So what about someone like me? So if you've tried a few lifestyle things yourself and you're still struggling with your menopause symptoms, what can health professionals, and I'm not just talking about me, I'm talking about GPs, gynecologists, other, nurse practitioners, what they can do to help, because I realise not everyone will be able to sort of see someone like me. So first of all, they can confirm the diagnosis, because often it can be hard to know what's menopause, what's not. They might sometimes exclude other causes. Sometimes they might do a blood test, check things like your thyroid, check your inflammatory markers, check your blood count, because there are some other conditions that can mimic the symptoms, but often you as a doctor can work out. But it is amazing how often I will see women who've been treated for mental health issues, been seen by a rheumatologist, been seen by a bladder doctor, and eventually someone will go, that's menopause. So it's having those thoughts in your head. So the key thing when you have an assessment about menopause is that it's individual to you. So everybody has a different backstory. You've got your own medical history, you've got your own family history as well, and that helps guide a health professional how to sort of treat you. And then of course what our job is to do is to help you make an informed choice about what sort of treatment is good and signpost you to that sort of reliable evidence-based information. So, and of course we can prescribe for you hormonal medication and non-hormonal medication. So we're coming on to HRT. So HRT, so I would say, hormone replacement therapy, or now it's menopausal hormone therapy is often called in other countries, is one word for a very large group of drugs, and let's just say they're very different and not one size fits all. It's very individual for each person, and some are better than others, I think. So it's quite confusing, HRT, and I remember when I worked as a GP, I would break into a bit of a sweat when people came to ask me about HRT, because I would it can be quite complicated if you don't know what you're doing, but then it is easier to simplify. And I know at the moment I hear time and time again that people do sort of say, I asked my GP, but they weren't sure what to do. And I think it's really important we do cut some slack to GPs at the moment. They're having quite a hard time, they're very busy, but also, it is important that GPs think of this, and even if they don't have time in that consultation, that the woman feels able to come back and talk about it again, and they're at least signposted to the right information or the right person within the practice. But HRT, just a sort of, my sort of guide, you can get patches and gels, what we call transdermal HRT, or you can get oral forms of HRT, as in sort of tablets. The type that you prescribe, it depends. The main hormone in HRT is estrogen. That's the bit that often will make you feel better. But if you're having estrogen and you've got a uterus, you can't have it without progesterone, because if you just had estrogen, it would stimulate the lining of your uterus and it would cause problems. You get bleeding, and you could even get endometrial cancer if we just gave you estrogen on its own. If you haven't got a uterus, then we can give you estrogen on its own, but otherwise we need to add in progesterone to protect the lining of the womb. And that can be via tablets, a patch, or some people might have the Mirena coil. You can use that as the progesterone arm of your HRT if necessary. So now the other thing that a lot of women get confused about is these sort of cyclical or continuous preparations. So if you're still having periods yourself, then you would need a cyclical preparation. So, and this is an important point, because a lot of women think, I can't take HRT because I'm still having my periods. No, that's wrong, because you might get the worst of your symptoms in the run up to your period stopping. So, but the key thing is you would need a cyclical preparation that would give you a regular, predictable period every month, hopefully a bit lighter as well. If it's been more than a year since you last had a period, then we can put you on what's called a continuous combined preparation, where you would take the progesterone every day as well as the estrogen, and then that would hopefully stop you having any periods or any periods coming back, but safely protect your uterus. So it is a little bit complicated, and that's why it's important that a health professional that knows what they're doing prescribes it. What about who can't take HRT? Well, in all honesty, there aren't many people out there that can't take HRT. There are very few contraindications. There's some rare sort of disorders. If someone's got active liver disease, we'd need to know that was stable before we sort of put them on something. Or if they've literally just had a heart attack, then I wouldn't want to start it right that very minute. Doesn't mean they can't start it later, but if it's only just recently happened, we might sort of wait for a little period of time. If someone's pregnant, they can't have it. And if they have estrogen dependent cancers, so it's not an absolute no, but certainly it would need to be in conversation with their oncologist if they were going to. So, but as preparations. So if you've got high blood pressure, you're better to have like a transdermal, or if you've got migraines. So people think, oh, I get migraines, so I can't take HRT. Well, no, that's wrong. You can take HRT, but you'd need a patch or a gel. You shouldn't take a tablet. Or of course, those people who have history of blood clots, like deep vein thrombosis, or it runs in the family, they might think, oh, I can't take HRT, but actually transdermal HRT doesn't increase your clot risk above the baseline. And sort of certainly, you know, if you're on HRT, you can still have your COVID vaccines, all of that. Let's just say COVID itself increases your clot risk much more than the vaccines do. So I would strongly say it's fine to be on HRT and to be having COVID vaccines. So, but of course, when we're thinking of HRT, the key thing everyone gets worried about is breast cancer. So I think this is a nice, again, this is from the Women's Health Concern website, which is the patient arm of the British Menopause Society. So really good, reliable, evidence-based information. And you can look at this yourselves online and read more information about it. But if we sort of say you had 1,000 women, if I'm trying to explain the risks of HRT associated with breast cancer, this is Davina in the ball pit yesterday, basically. So if you've got 1,000 women aged between 50 and 59, sadly breast cancer is common. We will see 23 cases of breast cancer in people in the general population. That's not on HRT. If you're on combined HRT, in other words, estrogen and progesterone, which lots of people will need, we do see an extra 4 cases of breast cancer. Now, I'm just going to put a caveat on this because this data is based on all the different types of HRT we have, including some of the older fashioned ones that we don't necessarily use anymore, that aren't as good as the newer ones, but we have to lump it all together when we're sort of trying to explain the risks to women. But it's very important we always put these small risks in context of benefits. And I just want to point out, if I can point out with my little pointer here, look at what happens to your risks of breast cancer if you're overweight or obese. And actually what I find often when women start HRT, they feel better, they feel like they can exercise more, they lose weight, and then actually they reduce their risk of breast cancer that way. And this is very relevant here in that if you don't have a uterus and you're on what's called estrogen only HRT, so you've not got progesterone in there, then we actually see 4 less cases of HRT. So it's actually protecting women from breast cancer. So if you've had your hysterectomy, what have you got to lose? You know, I think, you know, a lot of people don't realise that. And then the other thing to point out is, you know, alcohol. So if you're drinking more than 2 units of alcohol a day, it will increase your risk more than breast cancer will. So the majority of people that take HRT will not get breast cancer, but we cannot say there is no link at all because, of course, you know, we are all of the generation that we saw those, you know, scaremongering in the Daily Mail many years ago, and that was all from misinformation from this Women's Health Initiative trial where they had data showing women had more breast cancer. But actually what we found out was that actually the data was from women who were very overweight, who were over 60, who would have a higher risk of breast cancer anyway. So actually we became much more confident, but then 2019 again we were back in the negative press, and all this good work we've done, we saw there was a massive meta-analysis done again which was reiterating the risks, but there was a response to to sort of all that publication, and they have said, okay, hands up, HRT and breast cancer, there is a link, but it's very important we allow women to make informed choices, and remember that actually most women will not get breast cancer, and there'll be some women who cannot cope in their life without their HRT, so they mustn't feel bad or scared if they're on it. It's all about individualizing the risks and benefits for that woman. So I'm not going to spend ages running through these figures. This is the type of thing that your doctor would do with you if they were seeing you in clinic, weighing up a decision for you if you were thinking of starting breast cancer. But I'm just going to sort of say, so 5 years intake of HRT, start, you know, if you were on cyclical preparation of HRT, you're just seeing 1 extra case in 70 women. That's what this sort of recent meta-analysis has sort of added to the sort of risk conversation. So again, those risks are small and must be taken in context with the benefits. And that's where, you know, the other thing people will say to me is, what about side effects with HRT? What side effects could I get? Most side effects, if they do happen, will pass within 2 or 3 months. Often I'll review people at 2 to 3 months, and there's no coincidence. It's because I know that's when most of the side effects will have settled. But some people might get a little bit of breast tenderness when they start. That's fine. That's nothing to worry about. Occasionally people might get some headaches or nausea, bloating, irregular bleeding. But as I say, these things, if you do get any, and most people don't, most will pass. So we've talked about risks of HRT, but it's really important we put that in context of benefit. And yes, you know, it's going to help those symptoms. It's going to, and believe me, I haven't got shares in HRT or anything. This is a very balanced sort of approach to it. And there are some people who I don't think HRT is appropriate for, but I just think people need to know the good things, because there's so much media and negative press about the bad things. So it can make you feel better, so improve mental well-being, improve sexual well-being, reduce risk of osteoporosis, reduce risk of cardiovascular disease, reduce risk of dementia, reduce risk of bowel cancer, and as I've said, if you're on the estrogen-only preparation, we see a reduced risk of breast cancer. So it's really important that we think of that as well, and that's where the individualising your own medical history becomes relevant. So if you've got quite a strong family history of cardiovascular disease or osteoporosis, then you really should be thinking that, actually, you know, I really should be thinking about the benefit of this. And if we look at all-cause mortality in women, so HRT will actually, there was a massive study done looking at about 10,000 women, reviewing all the sort of data, something called a Cochrane review, and they noticed that all-cause mortality in women on HRT fell from 23 in 1,000 to 16 in 1,000, because actually most women in the UK will die from cardiovascular disease, not breast cancer. So we've got to remember that HRT can keep a lot of women safe for many years. But as I've said, some are better than others, and I have to be quite careful in settings like this that I'm not meant to promote any drugs one above the other. But it's only fair that I do share the sort of, you know, the information that we have. And one of the criticisms of a lot of that data that we're expected to share when we're helping you make your informed choice wasn't based on some of the newer forms of HRT, and as you're probably picking up, it's the progesterone part that's maybe more relevant when we're talking about risk of breast cancer. And actually now we're quite lucky because we have this newer progesterone called micronized progesterone, which is a lot more like what we naturally have. It comes from yams. And this is, it's called Utrogestin, a little capsule that you take as the progesterone arm of your HRT. And actually it's, we're now realising that that one is potentially quite a lot more breast friendly, quite a lot more cardiovascular friendly, clot friendly. So there are a lot of cases where that might be quite a good one for people to try, but not for everyone. And it's really important because not one size fits all. And some people might suit that one, but not everyone. And actually there's pros and cons with all of these different types of HRT. I've noticed sometimes some women can get a little bit more problem with irregular bleeding on that one. So you have to weigh up, you know, what's good about one and another, and it's very individual. One suits one person and one suits another person. So just because your friend's on a different one doesn't mean you should be on that one. It's it's important that we realise. But the one thing I will say about the data for that combination, if you were on sort of like a bit of estrogen, like a patch or a gel, and the micronized progesterone, then actually we see no increased risk in breast cancer for the first 5 years of use. So that is quite relevant. And a lot of women might be keen to sort of consider that combination. So a lot of people will say, what are these bioidentical hormones? What are those all about? Well, that was when women would go to London, and there are some private clinics where they'd have a blood test, and in theory their hormones would be matched to their own profile. As a doctor, or this is the take from the British Menopause Society as well, we can't really sort of advocate that because we have no data behind that. But I have to say, these clinics, I'm not saying that they're wrong or anything, but they as doctors, we have to work in an evidence-based way. But they have, to be fair, in that last 10 years when we've not had many menopause clinics, and they've offered a place for women to go and be heard and offer something better than nothing. But of course, it's very hard to comment on the safety of those. So what we do as doctors is give you what's called regulated body identical hormones, because, well, to be fair, estrogen is estrogen, sort of. And yes, it's not like the estrogens in the pill that are more synthetic. This is more like naturally what's in your body anyway, so that's why most people will get on with it. And the progesterones can vary, but as I say, we do have some which are more body identical than others, such as this micronized progesterone. So hopefully that clears that up for some people. What a lot of people aren't aware of is that we actually do have some non-hormonal prescriptions that can be used for menopause. And I know for those of you who watched Davina last night, yes, something that's very frustrating is people going to their doctors with sort of mood-related symptoms and just being stuck on antidepressants. And I agree that's completely wrong, because actually sometimes those people would benefit from hormones more. But there are some people who can't take hormones where it's not appropriate. Perhaps they've had an estrogen receptor positive breast cancer, so it might not be impossible to take hormones, but it might not be their first choice. So quite often they will take so these are some of the options, and I'm not going to sort of talk through the details of too much, but it's all about tailoring exactly what someone's symptoms are and then picking the right one. But they can be really successful. I use them a lot in the oncology clinic, and that they can really help with symptoms. So even if you don't want to take hormones, there are other things that you can try. Please don't feel there's nothing you can do. Right, are you all still there? Top up your wine. So we're going to move on to sex and libido. So let's face it, that's why you're all here. Vaginal dryness. Vaginal dryness is not just relevant when you're trying to have sex. For some people, they can get water infections. For some people, it's just painful even to sit down, rub on their. It could be really severe. And I'm just going to say, I liked the comment of saying everyone at age 45 should be given a topical vaginal estrogen, and yes, I'm partly in agreement with that, but maybe not everyone. But yes, really don't be afraid of using vaginal estrogen. Topical vaginal estrogen is not associated with an increased risk of breast cancer. Let's just say a year's supply of topical vaginal estrogen is the equivalent to one oral HRT tablet, just to sort of put it in perspective of what sort of low dose it is. So don't be afraid to use that. At this stage, a lot of women will need to use some lubricants. Your kind of KY jellies and things maybe aren't going to be ideal, but there's a sort of silk, yes. Again, I'm not really meant to be promoting certain brands, but you can get these over the counter. You can go on Amazon, you can get these yourself. We do have some newer things now coming out, something called progesterone vaginal DHEA, but it is still quite new, so we're not using a lot of it. Your GP wouldn't necessarily be able to prescribe it for you, but it can be useful with libido as well, but it's still sort of quite early days. I would still consider that if you've got vaginal dryness, I would start with topical estrogen. So libido's complex, isn't it? It's I think we've been through the pandemic, and I think there's not many people have been swinging off the chandeliers really, but it's at a stage of life where often our minds are quite full, you know, there's other stressors going on, so it's not just hormonal, it's other as well. Hormones don't impact libido, and for some people that doesn't matter if that doesn't matter within their relationship, but for other people it's hugely important, and so it is important we acknowledge it. I always like putting this slide in just to sort of make women feel better. We're complex beings, and I think you know, this is a good description of female sexual function. This complex control plan. You've got to tweak this, tweak that, tweak this, tweak that, tweak that, and if you're lucky, you might get there. As opposed to male sexual function, there's a gross generalisation. I'm so sorry for any men if they're listening in. It's probably unfair, but yeah, just to say men can switch it on and off. Women are be a little bit more complicated. So what can we do to sort of help with libido? Well, the first thing to say is, you know, communicate with your partner and let them know that, you know, it's not because you're not loving them anymore, it's your hormones, this is what's happening, and work together to sort of work at it. You know, if relationships are breaking down, you can access support and things like Relate. You can self-refer to counselling like that. Very important to treat your vaginal symptoms, because if you're worried it's going to hurt, you're not going to want to do it. So get that bit right, you know, and that will help. HRT, so yes, it definitely can help with libido. So particularly transdermal HRT, so a patch or a gel. Oral HRT I don't think tends to be quite as good, but you know, certainly some brands, some types help with libido more than others. Testosterone, so yeah, testosterone's, I always say if we're going to use testosterone for libido and it can really sort of help, it's very important you're well oestrogenized, you're on your HRT first before we add that in. I'm going to talk a little bit more about testosterone, and it's the old use it or lose it. It is true. So even if you haven't got a partner, you know, it is worth just thinking about, you know, sort of maybe using a vibrator as well, because it does keep the vaginal, the epithelial stimulated. There is some evidence that if you are using it, it stops it getting, you know, being quite so uncomfortable when you do go to use it. So testosterone is a little gel. The license was designed for use in men who have testosterone deficiency. So hence that means that if we're prescribing it for women, it's what we call off-label prescribing, and that's why sometimes your GP might not be happy to prescribe it, and that is fair enough. Often it's prescribed in secondary care, someone like myself, a menopause specialist or a gynecologist. But some GPs aren't always happy to continue prescribing it, so sometimes it does end up being a private prescription, just to sort of warn people of that. I'll put my hands up and I'll be honest, and I will say I'd say it's about 50-50. 50% of women who I prescribe it for think it's brilliant. The other 50% say no, didn't really make a difference. So it's a case of have a go and see, really. Highly unlikely to do any harm as long as used at an appropriate female dose. So the main risk if you are using too much, you could get male type side effects, which you don't want to be. But it's you know, it's a case of you can give it a go and see if it helps. I think sometimes it depends what type of level of testosterone you ran at when you were younger as to sort of whether it sort of makes a difference for you when you're using it. And just to say it's not just for libido. I find it works particularly well for those women who still the brain fog is an issue, and headaches and fatigue. It can really be useful for that as well, so not to be underestimated. And I am sort of working very hard at the moment to sort of try and get this brought in on our local guidelines so GPs can feel more happy prescribing it. And I know I've got other colleagues who are doing that in other areas within the UK. So yes, as I've mentioned, even, you know, we're all terribly British and we don't like talking about sex, but even the Queen is now, she's just endorsed Love Honey is Bath's local sex toy company, and which has done so well. Business has grown so massively that they even won the Queen's Award, so it's even approved by the Queen. So, and yes, just to say, you know, these things, they can be delivered very discreetly. If you do want to get a vibrator, you know, they don't always come with a big, you know, Love Honey thing on the box. So I'm all for women exploring that. You don't have to get a rampant rabbit, you can get a nice little subtle handbag sized vibrator. Right, so contraception. So I noticed there have been a few questions come in about that. So yes, it's very important. We might be saying, okay, you're in the perimenopause or you're near the menopause, or but we would always say you still need contraception for 2 years after your last period if you're over 50. Sorry, if you're under 50, and 1 year if you're over 50. So HRT is not contraception. So, you know, don't have that little surprise if that's not what you're aiming for. So I'm approaching the end now. Just I thought I would just make a little list of the typical type of things I hear and the misconceptions, and I notice it's reflected in a few of the questions we had through. Thanks for sending those and sharing those. So things like, I can't start HRT because I still get periods. Well, that's wrong. So as I say, a lot of people might start getting their symptoms in their perimenopause. It's just you would need cyclical HRT. I'm too young for the menopause. Well, as I've mentioned, very sadly, there are a small percentage of women who can get like what we call premature ovarian insufficiency. Even in their teens, this can develop. So we do need to sort of just be alert to the fact this can happen and sensitive to women. It's one thing going through your menopause at sort of 50. Imagine going through it in your 30s. It can be an extremely challenging time. And those women, I do think, definitely need to be well looked after. So the key thing is having it in your brain to think about it in case it ever happens to you. HRT will just delay the menopause and make it happen later. So yeah, no, that's not right. It's not that it's going to just come later. It's just helping you, supporting your hormones in a phase when your body's struggling to cope with that sort of change. So often, maybe after you've taken your HRT for a few years, you might stop it a few years down the line, and perhaps your body has adjusted and you think, oh, I don't need it anymore for my symptoms. You might still want it to protect your heart and bones, I have to say, but you know, it's not going to mean that you make it happen later. That's not the case at all. I'm too old for HRT. So after the age of 60, you'll notice that doctors start getting a little bit more nervous about women being on HRT and start sort of asking them to have it reviewed. But I have to say there are no arbitrary limits for how long you can take HRT. It's unfortunately your risks of things like breast cancer, clot and stroke increase. So as we get older, so what I would say is it's important to be on the right type of HRT, and probably your dose would be lower that you'd need if you're older. But no, some women will still need it when they're older, and they wouldn't thank you for stopping it, let me tell you. So I can't take HRT for too long. So that's a similar sort of point. So this is relevant because that recent review, that recent study did show that breast cancer risk is duration dependent. So that might be something that people want to factor into their decision-making processes. So the longer you're on it, the very slightly higher your risk is. But some women will need it, so they shouldn't feel bad if they need it. But if you're making an informed choice, you need to sort of be aware that the longer you're on it, the slightly higher your breast risk will be. HRT makes you gain weight. Oh, this one's a tricky one. So I think, yes, it can make you feel a bit bloated when you first started, a bit of fluid retention potentially. But in theory, it shouldn't make you gain weight. Most women on HRT would not gain weight. The fact is, when you're going through the menopause, that's the stage that you start gaining weight anyway. So people then will commonly think, oh no, this is the HRT that's making me gain weight, when actually it's just the fact that you're going through the menopause. And as I've said, you just have to try a bit harder, work a bit harder at sort of trying to keep that weight off and the good nutrition in and the alcohol low. Do as I say, not as I do. Any friends that have logged in tonight will be laughing at this point, knowing that you know, I don't follow my advice. So I've got bleeding problems with HRT, so I can't take it. So that's always a shame when someone starts HRT and they get bleeding issues. I would say just try a different type, hang in there. Often with manipulation we can find one that suits you. It's just a bit of trial and error till you find something that suits you as an individual. Don't give up. Normally we can find a solution, and it's, you know, a shame to give up because you know, you can get all those benefits that I've described. HRT gives most women breast cancer. Well, hopefully by now I feel like hopefully listening to my talk I've dispelled that. The majority of women taking HRT will not develop breast cancer, but you know, we have to all make our own choices, but we need to make sure we're looking at accurate information and not misinformation that's been around for many years. Testosterone will give me a beard. Well, it will if you use too much of it, but it's extremely unlikely to happen if you're using the right dose. I've had breast cancer, there's nothing I can do to help me, there's nothing I can take. Well, that's one I feel very strongly about, and some of you will be aware from what my intro there, I do the oncology specialist menopause clinic locally, well, both NHS and privately, with my lovely colleague Rebecca Bowen. And yes, there are lots of things we can do to help you, so please don't suffer in silence if that's you. And some of the websites I'm going to share with you link to information on that, because I know that's a very tricky, and that's a whole extra talk that we could give another day. So on the Women's Health website, on employment, so you know, if you're struggling at work and you think you need some advice, have a look at this, because it is really really helpful, so you can share it with your manager. So what to do if you're struggling? Well, we've talked about the life changes you can make, and hopefully hopefully I've not been too doctory or naggy. I'm going to share with you these online resources. There's some really good podcasts on Davina McCall. Her show last night, they saw a doctor there called Dr. Louise Newson, who I know and is a brilliant doctor who's done some really good podcasts for people to listen into, and I'd highly recommend that. They're very informative and evidence-based. Talk to your GP. I know that can be challenging at the moment, but you know, hang in there. You know, perhaps ask, is there someone in the practice that has an interest in women's health? Perhaps, you know, don't book in with the male older GP that's just about to retire. You know, get in with sort of one of the females, and you know, hopefully, even if you can't see someone like me, you should still be able to get good advice from your GP. And obviously, you know, there is more education going in for GPs now as well. We're very lucky in this area. We've got fantastic GPs locally, so you know, do persevere. And gynecologists, if it's so complicated, you could be a gynecologist or specialist menopause clinic, but that is easier said than done, particularly on the NHS. We don't have many of them, hence why I am doing this private, because there's a gap in care. But I did see, you know, I think down in London they have about 12, but there aren't many in the rest of the country really, but we are striving to improve that. So as I said, we do an NHS cancer clinic. If you are elsewhere and you want to sort of log in and see where you can find a menopause specialist, if you go on the British Menopause Society, there is a find a specialist link. And I think you'll, you know, what you'll know is that those people have actually done the proper qualifications to become menopause specialists. Otherwise, you know, be a bit cautious, because not everyone is a specialist. So, if you did want to see me, you're welcome. Feel free to take a screenshot of this. So I do, as they've mentioned, do specialist menopause here at the Bath Clinic, and I am happy to take self-referrals, and I also do remote consultations. So if you're not in our area, I am happy to do a remote consultation, because a lot of menopause advice can be done on the phone. BMI has a really good website you can book into. I think my secretary didn't sleep last night. She's a little bit worried after Davina was on, and then I'm doing this tonight, I think. So bear with her if she doesn't respond to you immediately. I also want to shout out my fabulous gynecology colleagues here, and this is for my sort of the local crowd who are watching. I'm very lucky. I'm very well supported here by a very good gynecology team, and you know, things like sort of postmenopausal bleeding. What that means is if you're bleeding over a year after having a period, they would be better to see you than me. If and if you want a Mirena coil put in, or you need a hysterectomy, or fertility issues. So they are more the ones that do that side of things, and again, take a screenshot. My breast colleagues are brilliant here, and some people might just want a bit more reassurance, might just want a bit of extra screening, might be worried about a lump or a bump. And again, we've got a really brilliant team here, and I can't recommend them enough. And as I say, I do this combined oncology specialist menopause clinic with Rebecca Bowen as well. We do that privately through the Bath Clinic as well as NHS. So hopefully that information is useful to you. So just to finish, I've talked too much and gone on. I hope you've topped up your wine as I've been going on. So don't suffer in silence. Hopefully you now feel, just like you don't get a prize for going through childbirth without any pain relief, you don't get a prize for going through the menopause without help. Think about, if you've got a daughter, would you tell your daughter to carry on suffering, feeling awful, feeling, impacting on their mental health? No, we're women, we shouldn't feel we have to put up with not feeling right, girl power and all that, but we sometimes have to be proactive and get out there and help ourselves. So we've talked about quite a lot of options. Do talk to a health professional if you're struggling. The key thing is it's individual to you, it's that individual assessment that's what's relevant. So this is some audio, you can't see that one at the bottom. This is some useful websites, as I've mentioned, the Women's Health Concern website. The other one I will point out is the Menopause Doctor one. That's the one with all the podcasts. And yeah, so again, feel free to take that screenshot, but I'm going to